Welcome everybody to this next webinar series in the ERN, European Reference Network, reconnet. Today's topic is introduction and overview to different subtypes of IIMs. And my name is Tobias Ruck. I am head of the neuromuscular department at the University Clinic Düsseldorf, Germany, and part of the IIM group within the ERN. And today we invited two very renowned speakers. We are very happy to have them with us. On the one hand, we have Professor Ingrid Lundberg from the Karolinska Institutet in Stockholm. And on the other hand, Professor Alain Meyer from the University Clinic of Strasbourg, both from the rheumatology departments, very renowned experts in the fields of inflammatory myopathies, several seminal publications, prizes, honors, too long to name them all. And before we start, I have some, let's say, housekeeping points. The webinar will be recorded and published on the ERN reconnet's website, as you can see here, and on the YouTube channel. For questions during the webinar, use the questions and answers session in the Zoom black bar or use the chat. Questions will be addressed to the speakers after the presentation. And with that, I'd like to start and like to invite Alain to share his screen. And we are happy to have you.
Thank you very much, Tobias, for this kind introduction. Thank you very much to reconnet for the organization of this webinar. And thank you very much to Professor Ingrid Lundberg for the co-presentation of this webinar that will be an introduction to different subtypes of idiopathic inflammatory myopathies. During this webinar, I will give you an overview of what are inflammatory myopathies, what are the signs and symptoms of inflammatory myopathies, and how to classify inflammatory myopathies. Then Professor Ingrid Lundberg will discuss how to manage inflammatory myopathies and the importance of combining pharmacological and physical therapy. So what are inflammatory myopathies? These are recently identified diseases. The term polymyositis first appeared during the end of the 19th century. And today, in 2023, according to the ACR criteria, schematically, inflammatory myopathies are defined by a myopathy, that is weakness, dysphagia, increased CK level, and evidence that this myopathy is autoimmune. And according to ACR criteria, this evidence includes dermatomyositis rash. But we will see that other extramuscular signs are important for the diagnosis. The presence of anti-G1 autoantibody, but we will see that other autoantibodies are also very useful for the diagnosis. And the presence of peculiar lesion in the muscle biopsy. Are inflammatory myopathies severe disease? Yes, they are. Mortality compared to the general population is globally fourfold increase, and during the first year of the diagnostic, mortality is even increased by a factor of 10. The three main causes of death of inflammatory myopathies patients are cancer, cardiovascular events, and lung disease. And this indicates that inflammatory myopathy should be promptly diagnosed and rapidly managed, especially for these three complications of the disease. Quality of life is also decreased in inflammatory myopathies patients as compared to the general population and as compared to several other chronic diseases. The main predictor of decreased quality of life are muscle, joint, and skin involvements, and this indicates that both muscle and extramuscular muscle involvement play a prognostic role in inflammatory myopathy. So what are the signs of symptoms of inflammatory myopathies. Following the ACI-EULAR criteria, the signs and symptoms number 1 is myopathy. The common characteristics of this myopathy is its proximal and symmetrical distribution, as illustrated in this figure, except for a subtypes of inflammatory myopathy that is called inclusion body myositis, that typically involve finger flexors, quadriceps, and gastrocnemius muscles, as we will see in more detail later. Typically, inflammatory myopathies patients complain of difficulty to walk, climb stairs, carry heavy loads for several months. Their CK level are about 3,000 units per liter, but there may be important variation in the severity of the weakness, ranging from normal strength to tetraplegia and or severe dysphagia, important variation in the CK level, ranging from normal values to more than 10,000 units per liter, and important variation in the chronology of the onset of the myopathy, ranging from several years, mimicking muscle dystrophy, to a few weeks. And thus, inflammatory myopathies should be considered in all patients presenting with a myopathy. Following the ACI-EULAR criteria, the sign and symptoms number 2 is dermatomyositis rash. But we will see that the systemic involvements in inflammatory myopathies are broader than dermatomyositis rash, frequently inaugurate the disease, and are a major causes of deaths or inabilities as stated in the previous slides. Inflammatory myopathies are definitely systemic disease. Dysphagia and skin rash affect about half of the patient. They are included in the current ACI-EULAR criteria of the disease. Skin rash in inflammatory myopathies will be covered in detail by Professor Petra de Haes in a dedicated webinar. In addition to these true systemic symptoms, polyarthritis affects 40% of the patient. Interstitial lung disease affects 30% of the patient. Raynaud's phenomenon affects 30% of the patient. 10% of the patient have a cancer associated with a myopathy, and 9% of the patient suffer from myocarditis. And thus, inflammatory myopathies should be considered not only in patients with myopathy, but also in all patients presenting with one of these systemic manifestations. Then, in a patient with myopathy and or one of the systemic involvements that we have just seen, what will be the diagnostic tests that will enable us to diagnose inflammatory myopathies? Following ACI-EULAR criteria, the diagnostic test number 1 is autoantibody. The majority of inflammatory myopathies patients have autoantibodies. Anti-G1, the only autoantibodies included in the current ACI-EULAR criteria, is present in 20 to 30% of the cases. Yet, about 20 other autoantibodies have been also associated with inflammatory myopathies. These autoantibodies are generally highly specific of inflammatory myopathies. Moreover, each autoantibody has been associated with peculiar signs and symptoms that we just have seen. As we will see later, this is highly relevant for classification of inflammatory myopathies patients. Yet, we should be aware that there is an important heterogeneity in the accuracy of current commercial tests for some autoantibodies. And thus, autoantibodies are definitely useful to diagnose and classify inflammatory myopathies, but caution must be taken in the interpretation of the results. Thus, Is there other diagnostic tests following the ACA, the ACA-ULA criteria? The diagnostic test number 2 is muscle biopsy. Schematically, this test consists in the analysis of the muscle lesions in 4 domains: the fibers, the vessels, the conjunctive tissue, and the infiltrate. These lesions are then integrated in histological patterns, as you can see here, and muscle biopsy improves diagnosis of inflammatory myopathies. Some histological patterns have been associated with peculiar signs and symptoms that we just have seen. This is highly relevant for classification of inflammatory myopathies. Yet, we should be aware that some histological lesions have a limited reproducibility, and thus the muscle biopsy is useful for diagnosis and the classification of inflammatory myopathies, but it should be performed and read by trained myopathologists. So, now that we have diagnosed inflammatory myopathies, how to classify them? Currently, there is no universally accepted classification of inflammatory myopathies. Yet, we all agree that inflammatory myopathies are heterogeneous diseases. Schematically, the myopathy is at the first front of necrotizing myopathy and inclusion body myopathy. On the other hand, extramuscular involvements are at the first front of dermatomyositis and overlap myositis that include antisynthetase syndrome and scleromyositis. And each autoantibody is associated with these subtypes and several histological patterns associated with these subtypes. And thus, the classification of inflammatory myopathies can be seen as the resolution of a 4-pieces puzzle, including myopathy, systemic involvements, muscle pathology, and autoantibodies. And this is important as the identification of inflammatory myopathy subtypes helps to personalize the care. As the last part of this introduction, I now would like to present you a brief portrait of each of the 5 subgroups of inflammatory myopathy. The first portrait is that of inclusion body myositis. In this subgroup, the myopathy prevails in the finger flexors, the quadriceps, and the gastrocnemius muscles. The onset occurs in middle age. The progression is slow. The CK level is not very high, inferior to 12-fold the upper limit of the normal. There is no systemic involvement nor associated cancer. Anti-CN1A antibodies can be found, but this antibody lack of specificity and sensitivity for inclusion body myositis. Thus, muscle biopsy is mandatory for the diagnosis. It notably shows an endomysial lymphocytic infiltrate invading muscle fibers. These muscle fibers are characterized by ring vacuoles and other abnormalities indicating autophagic deregulation. The second portrait is that of autoimmune necrotizing myopathies. In this subgroup, the myopathy prevails in the proximal muscle and of the lower limbs. The CK level is high, typically higher than 5,000 units per liter. Systemic involvement is rare and mild. The risk of an associated cancer is increased in the patient without autoantibodies. 2 autoantibodies are highly specific of this subgroup, anti-SRP and anti-HMGCR. Muscle biopsy shows necrosis of muscle fibers with no or mild inflammatory infiltrate. The third portrait is that of dermatomyositis. In this subgroup, the myopathy prevails in the proximal muscle of the upper limbs. yet the strength can be normal, and the CK level is highly variable from a patient to another. The common denominator of this subgroup is the rash of dermatomyositis that will be described in detail in a dedicated webinar. The patients of this subgroup have the highest risk of associated cancer, except for the patients with anti-MDA5 autoantibodies that are at risk of rapidly progressive interstitial lung disease. 5 autoantibodies are highly specific of dermatomyositis: anti-Me2, anti-TIF1 gamma, anti-MDA5, anti-NXP2, and anti-SAE. Muscle biopsy typically shows non-necrotic lesions of the perivascular fibers. Fourth portrait, antisynthetase syndrome. In this subgroup, the myopathy prevails in the proximal muscle of the upper and lower limbs, yet the strength can be normal, and the CK level is highly variable from patient to another. This subgroup is characterized by rich extramuscular involvements that include mechanic ends, Raynaud's phenomenon, polyarthritis, and interstitial lung disease. The hallmark of these subgroups is the presence of autoantibodies targeting amino acid tRNA synthetase. The 3 most common are, by order of frequency, anti-G1, anti-PL7, and anti-PL12. Muscle biopsy typically shows necrosis of the perivascular fibers. And the last portrait is that of scleromyositis. In this subgroup, the myopathy prevails in the proximal muscle of the upper and lower limbs, yet the strength can be normal and the CK level is highly variable. This subgroup is characterized by the most rich extramuscular involvements, including skin thickening, Raynaud's phenomenon, digital ulcer tips, polyarthritis, interstitial lung disease, and cardiac involvement. Several autoantibodies have been associated with this subgroup. The 3 most frequent are anti-PMSCL, anti-U1-RNP, and anti-KU. Recently, it has been shown that muscle biopsy typically demonstrates characteristic capillary pathology in this subgroup. As a conclusion of this first part, I hope that I have been able to illustrate that inflammatory myopathies are severe and heterogeneous autoimmune disease. So let's consider the diagnosis in patients with myopathy, but also with rash, polyarthritis, and interstitial lung disease. Confirm the diagnosis with autoantibodies and/or muscle biopsy, and classifies patients in each subgroup to personalize and tailor the care. I will be pleased to take your question at the end of this webinar. And now I leave the floor to Professor Ingrid Lundberg, who will discuss how to manage inflammatory myopathies and importance of combining pharmacological and physical therapy. Thank you.
See if So, can you see my screen?
Yeah, perfectly.
And can you hear me as well?
Also perfectly.
Okay. So thank you, Tobias, for your introduction, and thank you, Alain, for this nice introductory overview of the inflammatory myopathies that has really turned out to be a whole spectrum of inflammatory diseases. So I will just give a brief introduction of what to think about when we manage these patients. And then there will be a separate webinar in October by Professor Jirvankowski, who will discuss treatment more in detail. These are my disclosures. And this is also what Alain already told us. So if we now think about the inflammatory myopathies in general, so the overall goal is to improve function and health-related quality of life. For most patients, it is also to restore muscle strength and endurance, to eliminate inflammation and prevent damage. For some patients, the goal is to restore lung function. For others, it can be to eliminate skin rash or arthritis. Let's see if I see a hand. Is there a problem? Olga has raised her hand. Tobias, can you please just check so there is no problem with the...
Yeah, I checked, but
I can go on?
I think you can go on.
Okay, so as these are complex diseases, it's also important that the patients are managed in a multidisciplinary team where we have rheumatologists, neurologists, dermatologists, pulmonologists, physical therapists as some of the main experts. And the treatment is based on a combination of pharmacological therapy, but importantly also non-pharmacological therapy exercise. So when we discuss treatment of myositis, there are few controlled trials, and there are no recommendations that have been developed in consensus. So the most of the guidelines recommendations are based on clinical experience, case reports, series, and expert opinions. What I want to emphasize when we treat our patients is the importance of measure, and in particular in the daily clinic to measure disease activity, just as we do for patients with arthritis. And some years back, the International Myositis Assessment Clinical Studies Group, IMAX, developed a disease activity core set. And this core set is based on 6 items. It's the global assessment of the physician and of the patient or the parent in juvenile cases on a visual analog scale. So it's the test of muscle strength, and the proposed test is the manual muscle test. And that can be done on one side, as these are symmetrical, and then the maximum score would be 80. It includes a test of physical function, and the recommended test is the HAC, as we have also for RA. And then a test of the serum enzyme activity, and at least 2, like CKLD, for instance. And then importantly, also a tool to measure extraskeletal muscle disease activity. And this tool is demonstrated on this website, where you can find also videos on how to use these tests. And in particular, I want to emphasize that it's important to measure the muscle strength using this MMT, which is easily performed in the clinic. And you can see here it includes a test of proximal, distal, upper extremity strength, but also the lower extremities and neck flexor. And here is the website where you can follow this instruction by a video. Weakness of the manual muscle test is that it has a ceiling effect. So patients may feel that they are disabled, but the test is you have almost the maximum score. And this was one of the reasons for development of the functional index of myositis. And there are now even a shorter version. This is the functional index 2. It measures the number of repetitions in 7 muscle groups. And this is more sensitive to detect limitations of patients. And this is something we can use in the clinic. And the newer version includes 3 muscle groups. This takes a bit longer time. And we work closely with the physical therapists who perform these tests before the patients are seeing the doctors in our clinic. But this is also very helpful. So now to some recommendations of treatment, and that is also these I recommend reading this review by Dr. Odis and Agarwal in Nature Review Rheumatology. But as you can see, then these recommendations are still based on case series performed mainly with the old sort of subgroup in poly and dermatomyositis. So there is even less published experience from treatment of the new subgroups that were presented by Alain. But in general, patients with polymyositis, dermatomyositis are recommended to start treatment with glucocorticoids in combination with methotrexate or azathioprine. And if the patient does not improve or doesn't tolerate, then the second line treatment would be to change to mycophenolate mofetyl, a calcineurin inhibitor like tacrolimus or cyclosporin, or combine methotrexate and azathioprine. And as a third line therapy, there are suggestions to use rituximab, or in some cases cyclophosphamide, or other biological agents. For some cases, I think that something we will discuss further on later, you can consider to use high-dose IVIG even as first-line therapy. So that is can be relevant at all these levels. But we have few randomized controlled trials to lean on. So some years back, there was a report that about 50% of the patients are unresponsive to glucocorticoids. Side effects are common. A few patients fully recover their muscle function. Hopefully we will see some better results in the future, but what this told us was that it's important to combine the glucocorticoids with another immunosuppressive agent. And it's also important if patients don't respond, there could be different reasons. So it's important to, when you see the patient after maybe 3 or 6 months and they haven't improved, so reevaluate the diagnosis. Is this another type of myopathy? Is this a patient with inclusion body myositis or a muscle dystrophy or a metabolic myopathy, particularly in patients without skin rash? Or is there an underlying cancer that could explain the refractory case? And if the patients still have a weakness, could that be a glucocorticoid-induced myopathy? And when you have all these suggestions, then you can consider to repeat the muscle biopsy, which we do quite often. You can also consider to perform an MRI or combine MRI with a muscle biopsy. A special case is the patient with the interstitial lung disease. And the frequency of interstitial lung disease varies depending on the subset of myositis and how careful you look for interstitial lung disease. In our clinic, we found up to 70% had indications of an interstitial lung disease in patients with dermatomyositis, polymyositis, when we used HRCT and primary function test in all patients. But in patients with antisynthetase syndrome, up to 90% may have signs of interstitial lung disease. And as Alain said, interstitial lung disease may be the first clinical manifestation of myositis, and it goes with a high morbidity and mortality. And here we have even fewer or no controlled trials to guide our treatment. But in the same review by Dr. Odis and Agarwal, the authors suggested this treatment algorithm and divided the patients into those that had mild to moderate interstitial lung disease or severe interstitial lung disease. And for patients with mild to moderate interstitial lung disease, the experts suggested to start treatment with oral glucocorticoids or intravenous glucocorticoids, and then to continue with a combination of oral glucocorticoids in combination with mycophenolate or azathioprine, and as a second line treatment, cyclosporin or tacrolimus. And in refractory cases, you can consider to use rituximab or cyclophosphamide or combine mycophenolate and tacrolimus. But if you have a patient with severe interstitial lung disease, could be severe involvement, rapidly progressive, then there is a suggestion to start with intravenous glucocorticoid pulse therapy in combination with cyclophosphamide or rituximab. And then as maintenance therapy is similar as for the induction therapy, similar for those with moderate disease. But if patients are refractory with a severe disease, you can even consider to combine rituximab and cyclophosphamide. And of course, there are many different variations in how you use this therapy, and these are really our emergency cases in rheumatology. So then who is at risk to develop this severe interstitial lung disease? Well, from this large multi-center study with almost 500 patients, the risk factors to develop interstitial lung disease were people of age over 60, anti-MDA5 autoantibody, and some inflammation like CRP, and also reduced oxygen saturation. So of course, these are markers where we should be more careful and maybe more aggressive in our treatment. And it's also important that we follow patients with interstitial lung disease with spirometry, the pulmonary function test, to measure the effect of the treatment on the pulmonary function. And it's suggested to repeat the pulmonary function test at least every 3 to 6 months in the beginning. If patients are deteriorating, you can repeat this test even more often. And also to repeat the HRCT of the lungs if the patients deteriorate or if there is a concern for maybe an infection that's complicating the disease. For patients with a rapidly progressive interstitial lung disease, I think the overall recommendation is to use aggressive treatment and tight monitoring. And it's important to discuss lung transplantation early. And here ECMO may serve as a bridging therapy until the patients can be considered for lung transplantation. But the close collaboration with the lung doctors is really to be recommended. And then I also want to emphasize that treatment of myositis should not only be focused on the pharmacological treatment, but also of exercise. And I think we should hear more about this during the coming webinars. So when I started in rheumatology some years back, treatment of myositis was based on pharmacological treatment, and patients were told to rest as we were afraid that physical exercise may worsen the inflammation in the muscle. Together with the physical therapist Helene Alexandersson, we set up a very modest exercise program, a home exercise program, as you can see here, including a warm-up and mobility and strength training in different muscle groups to avoid overuse. And we did this for 12 weeks, and these were patients with stable disease, without any signs of disease activity. And with this modest program, we could actually improve the strength, as you can see here, with the tests that we did during these 12 weeks. Well, this has encouraged us and others to perform more studies and controlled trials. And here I just present the results of one controlled trial that we performed in patients with polydermatomyositis that included exercise on biking on a load of 70% of their VO2 max in combination with the muscle endurance training in different muscle groups. And the patients did this for 12 weeks, 3 times a week under the supervision of a physiotherapist. And then we had a control group with myositis patients who continued their their level of exercise that they had done before. And in this controlled study, we could actually measure an improved performance of cycling, improved fitness, and also importantly, we can see that patients in the exercise group also improved in the disease activity, although we didn't change any of the pharmacological therapy. Whereas in the control group, we didn't see any improvement on the disease activity or the other variables. So when we now come to the role of exercise in myositis, we can say it's safe. It's safe to be performed also in the early disease. So as soon as the patients can start to do exercise, we recommend it. It's also effective on the performance of muscle, improves strength and fitness, and it may reduce inflammation and fibrosis. And we have also measured that there is an effect on capillary density. So exercise is an important complement to pharmacological therapy. But still, we don't know which is the best type of training, and we are trying to develop some experience and recommendation for this. So now to summarize treatment in myositis in an overview way, we say myositis is a complex disease, and it's important that we manage these patients in a multidisciplinary team. And I think we should move towards individualized treatment according to clinical phenotype and serotype. And it's important that immunosuppressive treatment is combined with physical exercise. But we still need to identify predictive markers for treatment response, as now we more or less treat all the patients the same. So we need new therapies, new therapeutical options, and for this we need to understand more of the disease, and for this we need international collaborations. So finally, I would like to invite you who are interested in these patients to join our international effort, where we have a register where we can follow the patients, the MyoNet register, before called Euromyositis, where we can follow the patients and then learn from them, from our experience. And for this, we have in our register, we have now more than 6,000 patients that we can learn from. So if you are interested to join this collaboration, you can contact me or Dr. Hector Chinoy in Manchester. So we welcome new collaborators. And I will stop there, and I think we are ready to have a discussion. Thank you so much.
Yeah, thank you so much as well, Ingrid, for the great talk. And yeah, we do have two questions right now. First question goes to Alain. It is from Petra de Haas. In the current EULAR ICR criteria, muscle biopsy is not mandatory. Should this be adapted, since this seems to have important consequences to subclassify the patients? You have to unmute yourself.
Yes, thank you very much for this question. So actually, currently, there is no recommendation for muscle biopsy. Should we perform it? Should we not perform it? Should we perform it only in some patients? So my response will be a personal view, and maybe Ingrid or you, Tobias, would like to complete it or bring some other information. But as I see muscle biopsy, there is two scenario. The one is a patient with a typical clinical phenotype and reliable autoantibodies, for example, G1 or anti-Me2 or anti-MDA5. In this case, muscle biopsy, in my opinion, is not mandatory because it is an invasive test. And also you need, as I say, a trained myopathologist that is not always available. So this is the first scenario, a typical clinical phenotypes and a reliable autoantibodies, and the muscle biopsy could be not mandatory. And there is another scenario that is you have only a muscle disease and the extramuscular signs are absent or they are not so typical. And you have no autoantibodies, although autoantibodies is not so reliable. In this case, I think the muscle biopsy is mandatory. And just for an example, the more demonstrative example is inclusion body myositis, because in this case we have no reliable autoantibodies, so definitely muscle biopsy is mandatory. And finally, I just would like to complete for muscle biopsy in the future, because I haven't time to mention that there is probably a lot of information in muscle biopsy regarding the prognosis and the response to treatment, and there is a lot of work that have been published on this topic. So maybe in the future, muscle biopsy will provide us more information to personalize the care and to perform a medicine that is more precise for the patient.
May I comment also on this?
Of course, Ingrid,
Yes.
go ahead.
So I think I really advocate to perform muscle biopsies as a part of the diagnostic procedures. But of course, there are some instances that you may not absolutely need it to support your diagnosis. But if we look at the ULAR ACR, these are classification criteria. But here in these criteria, we developed two versions, one for patients with and one for patients without muscle biopsy. But then please notify that you can use the version without muscle biopsy only for patients that have this typical skin rash, and preferably you should do a skin biopsy to support your diagnosis in these cases. So if you come to a phase where you want for a clinical trial, where it's suggested to include patients and they use the ULAR ACR classification criteria, it may be needed to perform a biopsy to include a patient there. But of course, there are also, but patients with typical skin rash and muscle weakness, you may not need that because then you can still classify the patients. But I support it because sometimes there is, as you say, particular patients with myopathy, and there may be other underlying diseases, also with inflammation, that may not benefit from immunosuppressive therapy. You're surprised sometimes that you find these muscle dystrophies or metabolic myopathies.
Yeah, I can't agree more. We in Germany are very suggestive of muscle biopsy, and for differential diagnosis, it's very useful, but also to know more things about pathophysiology and maybe for, let's say, tailored therapies. So yeah, we are very suggestive of or supportive of muscle biopsy. We have two more questions. Thank you. From Olga. It was a question, not a problem. The question is there a constant inflammation in the muscle, even if the disease is in remission? So each of you can answer. Maybe Ingrid, you can.
Yeah, we have done some follow-up biopsies. We do that routinely for a research project. And I'm surprised that we find inflammation also after 6 to 9 months with immunosuppressive therapy, even though the patient has improved. And if this inflammation means that there is increased risk of relapse, we don't know. But I think this is something we should be aware of, that it may be, you may not totally delete the inflammation by the current treatment, but in a low grade, it may not affect the performance. It may also be that the cells, like the inflammatory T cells, they are they're not dying. They're very resistant to treatment, but they may not do any harm, but they may increase their activity. But we know very little, but there is a possibility to have sustained inflammation even after treatment.
Thank you. Does this answer the question? If not, please tell us. I think so. Another question was, I don't know from whom, but do we foresee an earlier use of rituximab? We know the RIM trial, but yeah, the evidence is not that good as we wish it to be. But do you foresee something like that? Maybe Alain, you can answer this right now, even if the topic was Ingrid.
Yes, this is a difficult question. Generally speaking, the more early the treatment is performed, the better the prognosis is. Yet on the other hand, rituximab have of course several side effects, especially hypogammaglobulinemia and infection. So it depends on the benefit and the risk. And the other aspect I would like to mention is that not all myositis subtypes respond in the same way to rituximab, especially in the RHIM trial. One of the predictor of a better response was anti-GO1. So I'm not sure that the rituximab will be given earlier than presently. I would like also to highlight that that we have made in the past 10, 20 years a lot of progress in the diagnosis and classification of criteria of inflammatory myopathies, and now there is a lot of trial dedicated to inflammatory myopathies, and so I would like to encourage the inclusion in the trial in order to enable the emergence of drugs that will be dedicated and approved in inflammatory myopathies, because currently there is only one type of IgIV that is improved for the disease, and I think we could do better. So I would answer earlier inclusion in clinical trial dedicated to myositis.
And maybe an add-on question, but a little more specific for anti-SRP positive myositis not responsive to glucocorticoids. Which immunosuppressant do you suggest? Is it rituximab or cyclophosphamide? What is the best choice or better choice in your opinion? Anti-SRP.
Sure. Maybe I can answer just
Sure.
the suggestion from the, there is a publication from the European Neuromuscular Center group. It's also based on expert opinion, but I think there is suggested that if you have a patient with anti-SRP positive myopathy, it's recommended to start to come in combination with glucocorticoids with methotrexate, and you can go up to 25 milligrams per week. If the patients do not improve there, the second line therapy has been suggested to be rituximab. But as an alternative, also IVIG, but I think there we have even less data, but that's from that publication.
And this is another add-on question, because you said IVIG. An anonymous viewer wanted to know what is the mechanism of IVIG in myositis treatment.
Do we know that? I think we don't know.
I don't.
There are some studies, but there are only guesses, I would say. Or Alain, do you have any comment on?
No, and I hope I can respond to this question, but I cannot. But I'm very interested in the response if someone has it, and we should. There is work on this question, so I hope we can answer in several years.
Yeah, but we don't know it for any of the autoimmune disorders. We use it.
No,
yeah, many suggested mechanisms, but we don't know. A last question to therapies. Is there any preference for MMF, MTX, or azathioprine?
I think it depends on the individual. For most experts use now, I think methotrexate as the first line therapy. because we are used to that from other diseases, from arthritis. From scleroderma, we have learned that MMF may be just as effective as cyclophosphamide if patients have lung disease. But I think depending on the age, risk side effects, involvement of the lungs, and so on. But I would be happy to hear both your opinion, Tobias, and Alain's.
Yeah, not based on evidence, but many times my first choice is MTX as well. I see many liver problems with the azathioprine, with CellCept. I have the feeling that the efficacy is not as good as for MTX, but there's no evidence at all. So yeah, have the same feeling as you.
Yes, I also share this experience, especially regarding the tolerance of methotrexate. So as I can use it, I use it because especially the risk of lymphoma that exists for azathioprine MMF does not exist for methotrexate. So this is, I think, a good point for methotrexate.
In the meanwhile, we had some more questions on the biopsies. Is there a place for needle biopsies to facilitate procedure?
I'm happy to start discussion. So we use not the needle biopsy, we use the concotome biopsy, which gives some larger cross-sectional area compared to the needle biopsy, but of course it's smaller than the open biopsy. So the needle biopsy gives a very small cross-sectional area, but it's a sort of a long piece you get. So it's ideal for enzymatic, or if you want to, or protein analysis, but maybe less efficient or less good for the histopathology because of the small cross-sectional area. You get quite a sample which is very selected. So I would recommend to use the concotome biopsy instead of the needle for when you are doing the diagnostic procedure for when you want to look at the histopathology. But maybe you have other, of course, open biopsy, you get a larger even representativeness, but it's more, as I said, the open procedure requires some more arrangement and maybe a special room and so on. So then we can do the concotome biopsy. We have there is on YouTube, you can have a video, look at how you do the concotome biopsy.
Oh, you have to share the link.
Yeah, I will.
Yeah, anything to add, Alain?
We also do not perform needle biopsy because the material is not so good to analyze the lesion, especially the topography of the lesion with needle biopsy. And in France, the most widely used technique is the open biopsy, but I think this is an habit, and we like it because finally it's not so complicated. But we have to. There is also a YouTube demonstration of our colleague in La Pitié-Salpêtrière from neurologist. So rheumatologists can do it. I do it. I think to be sure that you have muscle, in my experience, it's very good. But of course, there is a little scare that is present after the procedure.
We had another comment on now skin biopsy. The problem is that the histopathology of skin is not always so specific. We base more on the clinical aspects of the skin rash, and only in doubt we take skin biopsy. How do you proceed or recommend skin biopsy?
That's the same as we do, but for the criteria work, our dermatologist Vicky Worth, she emphasized that sometimes it's important to perform the skin biopsy not because you have, we are aware of that, you don't have any absolute specific findings, but there are also some other conditions that you may exclude with the skin biopsy. That was her argument. But we don't use the skin biopsy in routine.
Yeah, we neither. Another question refers to the stopping of immunosuppressants with a flu, so with an infection, and how long the treatment can safely be omitted. Unfortunately, the immunosuppressant is not specified, but let's say it's MTX or azathioprine. How long can we stop or pause without any risk of severe disease flares?
Very little data on this, but we recommend the patients to make a break as long as they have fever or a severe infection, maybe a few weeks, but otherwise usually 1 week until, or if they are on antibiotics, until they have finished that. But I'm not aware of any consensus recommendations on this.
Me neither. Alain, any other ideas?
No, in myositis, I have no information regarding rheumatoid arthritis. Obviously, it is not the same disease, but the methotrexate can be stopped during 2 weeks after vaccination to increase the level of antibodies against the pathogen. So it may indicate that during 2 weeks. And as I not mentioned, the patient do not experience flare during this stop, so it may indicate in some autoantibody, some autoimmune disease, maybe in myositis also, stopping 2 weeks is not harmful for myositis.
Maybe a last question to ILID. Is antifibrotic therapy nintedanib of any role in ILID treatment?
We have very limited experience of that. There are only a few cases with myositis that were included in the trials. So I think this, there were some abstracts at EULAR, but I think we need to have more experience before we can see if it has any role in these patients. There have been some case series also with rapidly progressive ILD, but I think it's too, my opinion is too early to have any recommendations. But what is your experience?
Yes, it is the same, because clearly the impression is that my impression is that pathophysiology of interstitial lung disease in myositis is very different from idiopathic pulmonary fibrosis, interstitial lung disease associated with RA, and also with systemic sclerosis. Especially when we treat the patient with immunomodulatory drugs, we see a clear improvement in the function, in the TLCO, and also in the lesions that we can see on CT scan. And this is very different to what we observed in RA and in systemic sclerosis. So it made me think that the pathogenesis is very different, and it may conduct to a different use of antifibrotic agent. And clearly, I prefer to change the immunomodulatory drugs rather to prescribe an antifibrotic drugs that only slow down the disease and do not improve interstitial lung disease.
Maybe I totally agree. I mentioned there is an ongoing collaborative network on treatment management of patients with ILD and connective tissue diseases. So that is a collaboration between European Respiratory Society and EULAR. So hopefully this study group will come out with some recommendations, including the use of antifibrotics in the different and immune modulatory drugs, and how we should follow these patients. But maybe in the fall we will have some reports from this group. I think it's a big effort to try to combine these conditions, as they are quite different, as you say.
So the last question, we started a little bit late. When we use IVIG for the treatment, maybe a short answer.
We use it quite rarely because of the high costs. I must say we rarely use it. We don't, in a few patients with anti-HMGCR positive necrotizing myopathy that have intolerance or risk factors to use, for instance, high-dose glucocorticoids, there could be a case when we use it early in the disease. But otherwise, it's refractory dermatomyositis, refractory cases for us.
Yeah, we use it as add-on therapy. Unfortunately, it's paid by the insurances for dermatomyositis and polymyositis in Germany, but of course, it's always related to the costs.
And quite unspecific effects as well.
True. Yeah, with that, I'd like to thank you, especially thank the speakers and you for the great discussion and all your questions and your time. Yeah, stay tuned. Watch out for the next webinars from the IIM group. We have seen it in September and October. Next webinars are upcoming. Yeah, and now I wish you a nice evening. Thank you all.